Well, thank you, Manolis, and again, great pleasure to be speaking here after two great presentations, two outstanding presentations. I'm always hopeful that I'll live longer if I listen to Professor Selbasagi and adhere actually to the dietary recommendations. The question is, what do we do with those patients that cannot adhere to those and that are treatment refractory, if you'd like, second tier of weight management, and pushing it to the very corner or the maximum we can achieve is, of course, then talking about bariatric interventions. And this will be my task in the next 20 minutes. And the main disclosure here is I'm going to give you the hepatologist perspective. So I'm going to be talking about weight loss, yes, but I'm going to be asking myself, is that beneficial from the liver phenotype? And please consider that. These are additional disclosures I'd like to share with you. And let me start with a background briefly. We've heard about non-alcoholic fatty liver disease. I'm going to give you my German perspective. We had the privilege to study a population-based cohort here in Germany, 15,000 people living in Germany, in my neck of the woods, as you might say. And we observed relevant liver disease in that population. Fatty liver index, which is an imperfect test at the population level, could be useful. 37% of the German population not being referred to anything, but just living in Germany positive. And I think the striking finding here is advanced fibrosis, FIB4 above 2.67. We've heard different cutoffs today. So 2.67 is 1.1% in the German population. Male sex and age, of course, being risk factors for this advanced fibrosis. And how can we address this? And of course, if we talk about NAFLD and obesity, I think obesity that came up is a root cause of liver injury here. It drives lipotoxicity and liver injury. And while we have lifestyle interventions, how can bariatric surgery, and there's a lot of data that I want to show with you, and maybe bariatric endoscopy, there's clearly less data on that, help our patients. And the interesting aspect, there's clearly, or most related to weight-dependent effects, but maybe there's a little bit of weight-independent effects. The question is, how do you deter the gastrointestinal tract after certain surgical procedures or even after certain endoscopic procedures? I think that needs to be cleared out. If we look into the guidelines, and that has been mentioned, we need guidelines to follow and adhere. There are clear statements that calorie reduction or total body weight loss of around 7 to 10% is what EASL recommends here. And the important thing is not only to achieve that, and I think Professor Selbasagi mentioned this, it has to be maintained and adhered, and there are cycles of regaining weight back, which are probably not too good for those patients. So maintenance is important. And of course, this could be one question or one aspect that's very well addressed by bariatric procedures. And there's actually a clinical practice guideline by the American Gastroenterologist Association, ASLD, on the use of intragastric balloons in obesity. So again, here, key recommendations is aiming for weight loss, and they actually address non-alcoholic fatty liver disease, and they say, to decrease liver fat, inflammation, and fibrosis is something that can be achieved or can be looked for in patients with non-alcoholic fatty liver disease. And again, my perspective on those metabolic risk factors, and this is some NUHANS data and some data we generated from our tertiary referral center. Of course, diabetes and a BMI above 30 are the key drivers or the key risk factors of having advanced fibrosis. So it makes sense to address these potentially with therapeutic interventions, including bariatric surgery. Lifestyle interventions we heard about. There is some medications addressing weight loss by now, and we heard the diabetic benefit and potentially the liver benefit of GLP-1s. But then I think I'm going to be talking about the endoscopic therapy, which is a little less invasive compared to the bariatric surgery, but the evidence clearly is stronger from the liver and weight control perspective for bariatric surgery. So I want to start with this section. Here's a very nice paper published in 2020 in the New England Journal, Life Expectancy After Bariatric Surgery in the Swedish obese cohort. A lot of patients that went into that study, and the interesting point is I think they have both the surgery group here, 2,000 patients. They have a non-surgical control group, and they have a reference group, which is the healthy population that was selected. Well, the first message is bariatric surgery is very effective in reducing weight, and we're not surprised. You can see the body mass drop here in an obese population. Again, the indication to do bariatric surgery, BMI above 40 or 35 in comorbidities. These patients drop their weight. They do not come back to a normal range, but it's a significant reduction, and that's maintained over this follow-up that's over 20 years in this study. And I think this is, of course, a very important message and point for the patient. And they report on overall survival, and you can see the reference cohort up here, and you can see the control cohort was just less, and actually the bariatric surgery group is able to separate from the control cohort and does not quite reach, of course, the reference cohort, but the survival at that time that's being explored was clearly higher. And if you look into the deaths and complications, because that's obviously one aspect of bariatric surgery, we're doing surgery on a patient with potentially complications in this study, 90 days being reported here. In the second table I'm showing you, there are 5 deaths that have occurred, so clearly this is dramatic, but it's something that we know can be associated. But overall, the numbers, I have to say, are fairly low. And a second study that has been published in the New England Journal, I'd like to, so this is also, before I move on, reduction in overall cardiovascular risk with a hazard ratio of 0.7 here, and I think this is for sure numbers we have to keep in mind if we counsel these obese patients. And there's also something that I always like to just highlight, because it was also published in the New England Journal some years ago. There have been signals of increased suicidal behaviors following, in particular, Roux-en-Y surgery. So I think we have to keep those potentially adverse effects, which can be very dramatic for the patient, leading to death in the extreme, in mind, and balance them versus a strong effect on complications and a beneficial effect on survival in this study, at least. And now talking about more liver-specific effects, there's a number of studies that came out of France and that are very interesting. Here's one that's been published in Gastro. It's an exploration of a large bariatric cohort that underwent bariatric surgery at this center, and they were assessed for liver disease. So I think the first important message here is the indication to perform bariatric surgery is obesity, and you can see that actually there's patients with paired biopsies. There was only 7.7% of those very obese patients that had NASH. So that's also my personal experience. If we study bariatric surgery cohorts, they are not referred for liver disease, and clearly they are, the prevalence of liver disease is here a little lower, or it's not the main target population maybe. But anyways, in that subgroup with paired liver biopsies, you can see that before and after surgery, and the graph on the right shows you the resolution of NASH, no NASH at biopsy. Well, there was at least NASH at the baseline, so 85% of patients normalized their histology in terms of the NASH assessment at 1 year, and I think that's a very strong argument and result here in terms of NASH resolution. Interestingly enough, and I'm going to follow up with a second paper on that, there's been mostly benefits for fibrosis regression. You can see that somebody was baseline stage 1, they ended up in stage 0 after 5 years, and the green cases are the ones that improved. Interestingly, there are very few, but some progressed, and even a case of cirrhosis in a patient that was pre-cirrhotic at baseline, maybe misclassified, but for sure, not all the fibrosis resolves following bariatric surgery in the 1-year observation cohort. And this is a very nice study, again, from the Paris group here, that's been presented at AASLD and published in Hepatology by now. That kind of shows the same thing. It's a bariatric surgery cohort that has been explored and with a follow-up that's been done by liver biopsy. And they've looked at the cases, in particular focusing on advanced fibrosis, so F3 and F4 disease cases. And while they saw a lot of resolution in terms of steatosis and activity grade, actually in particular in the advanced diseased group, advanced stage disease group, the resolution of fibrosis was significantly lower compared to the other aspects. So what does that tell us? I think in the observational time point or time frame here, which is 1 year, fibrosis doesn't just dissolve. It takes time to dissolve fibrosis. I think that bariatric surgery is an effective measure, and if you follow those patients longer and the metabolic health aspects are being preserved in these patients, the benefit will prevail for these patients. And why am I saying that? And careful, now so there's more in-depth data that I wanted to share with you here. This is actually looking into the paper where they saw that actually 3 or 4 cases progressed, or 2 cases progressed, 5 were stable, and 10 regressed in the advanced fibrosis cases. They've used a little bit of a different fibrosis scoring system as we are used. Again, this is a 7-tier system. It doesn't make a huge difference for this type of analysis. It shows us that not all cases resolve. 30% had normal histology at follow-up. There was 74% of NASH resolution without fibrosis progression, which is an accepted endpoint we're studying in clinical trials here. There was 70% of at least of 1 stage of fibrosis regression. And again, the number that I highlighted here, half of the patients with advanced fibrosis kind of persisted. And the risk to, the hazard ratio to persist in terms of advanced fibrosis with age, and interestingly, sleeve gastrectomy here as a procedure. If you look at it from the other way, table 4 on this end here, the independent predictors of achieving normal liver histology was a higher baseline NAS and a higher decrease in BMI. So this paper shows nicely weight loss is associated with advanced fibrosis or improvement of fibrosis, but it's not, advanced fibrosis is not going away within 1 year. And now I'm coming to the slide where I'm cautioning you, because this is not a NAFLD data set. This is HBV, and we haven't seen anything on this. And, but it shows nicely that in a context where a chronic viral infection being treated with a very high effective drug, namely tenofovir here, with paired liver biopsies at 1 and 5 years, you see that patients and fibrosis stages shown in Ishek scores here took time to resolve their liver disease. So within 1 year, you had mild changes. Few patients changed their Ishek score. But at 5 years, you actually had a significantly stronger resolution of fibrosis. And this is always something we're talking about. You know, it takes time to actually improve fibrosis. And this will be the same in non-alcoholic fatty liver disease. So another very important study, and it was co-authored by Naeem Al-Khoury, who's here in the audience today, came out of the Cleveland Clinic. It's a retrospective cohort study, and they looked at patients that underwent bariatric surgery and choose a non-surgical control group as a primary comparison, and looked actually at outcomes and events at the time frame of 10 years, up to 10 years. And they defined both major adverse liver outcomes, MALO, but also a major adverse cardiac event, MACE. And something they showed here, that in the bariatric surgery group, both the incidence of liver-associated outcomes and the incidence of cardiac-associated outcomes, or MACE, is significantly reduced, with an absolute risk difference of MALO of 12.4% in this group. A very nice analysis, I think, moving forward, highlighting that by addressing weight loss in this bariatric cohort, you could prevent liver outcomes, and I think that's an important message for us in the field. So how about bariatric endoscopy? I mentioned at the beginning that clearly there's less data on this, but I want to show you some studies that have been published. I'm going to be talking about the intragastric balloon, but there is also something called endoscopic sleeve gastroplasty. So instead of doing surgery, you can do it endoscopically and kind of stitch off parts of the stomach, mimicking a sleeve gastrectomy, not to the same degree, but reducing stomach volume significantly. And the first study I'm showing you here is one using the intragastric balloon, exploring transient elastography as a surrogate of liver disease. And it's a small retrospective analysis. You're seeing we're moving into an area where we have 26 obese patients being studied with an increased liver stiffness at baseline. And the significant body weight loss defined as more than 10% was achieved by 16 patients, and 10 achieved at least 7% weight loss, which is in the range we're aiming for. And the regression of fibrosis stages as assessed by transient elastography was actually associated with the amount of weight loss. And both at baseline and follow-up, you can see here again in this population that had an elevated transient elastography reading in the beginning, it comes down during the follow-up, and this is only 6 months because this is the time frame where you use these endoscopic bariatric devices here. So 15 patients improved categorical in the fibrosis stages. Okay, so another data set on the use of the intragastric balloon, and comes from the Mayo Clinic here. Again, small study, 6-month follow-up, typical for this type of studies, but it used histology. That's why I'm showing you it here. And they are explored in these graphs left before, on the right of each category. Steatosis, ballooning, inflammation, NAS score, and fibrosis is the post biopsy. It was done very interestingly enough, ultrasound guided during the removal of the balloon, so you're very close to the liver and you can endoscopically guide it, get a liver biopsy through the stomach without having to go percutaneously. And something you see here, that there's at 6 months a strong effect predominantly on fat. So a lot of normalization in the blue, less so in the fibrosis stage, but again, not very surprised on that. And 73% of patients had an improvement on 2 points or more in the NAS, which is mostly driven by steatosis in this cohort. Last data sets, because I wanted to mention the endoscopic sleeve procedure here. This is a little bigger study, 118 patients with obesity and fatty liver. Not so robust liver data in this study, but you can see that there is a pronounced weight loss, which seems to outperform the intragastric balloon a little bit, 15.5%. And they're showing the change in HOMA IR here, so clearly effective for weight loss and improvement of metabolic parameters. They do not have a whole lot of liver data, but they are showing a yearly absolute change in ALT. So it's a 2-year study, so patients decreased their ALT by 10, which is, I don't know what to make out of that. It's not impressive, but it's somehow going in the right direction, I would say. So there is evidence that also by this procedure, you can get through the weight loss and the improvement of metabolic parameters and improvement in liver changes. My last slide. I think in the field of non-alcoholic fatty liver disease, we're discussing combination therapies, and the cartoon is again taken from a study that Naeem Al-Khoury published recently. We're combining different drugs with different MOAs to achieve resolution of steatohepatitis. So my thought goes into the direction, why not use bariatric procedures in combination with drugs potentially, food for thought, adjuvant pharmacotherapy that could be started after patients regaining weight after bariatric procedure, and I think there's some data in the literature on that. But of course, we could also discuss whether we shouldn't be using an antifibrotic, for example, from the very start, and give this to patients that undergo bariatric procedures to kind of expedite the process of fibrosis resolution. The question is, would that be a beneficial approach? I don't know. On the con side, there are clearly safety considerations in the context of rapid weight loss, and then procedural risks, but also drug side effects. So I'm happy to follow up on that in the discussion if there is enough time. And I'd like to thank you so much for your attention, dear Chairman. My summary is, I think bariatric therapy is highly effective for improving weight and metabolic parameters. It's established here. The data related to liver disease is not as strong. They have low complication rates, but clearly there are complications associated with bariatric procedures. It takes time to improve liver disease, but again, very important data showing that liver outcomes could be reduced, in particular over time. And the question is could this be a therapeutic bridge or address a gap in certain patients? Thank you so much.